Okay. Good afternoon and welcome, everyone. Today is Women's Heart Health Day, but for those of us in Ontario, we awoke into a winter wonderland. And I trust all are well. I'm Dave Nilopovitz, and on behalf of our team, I want to welcome all of you to the first OC3PR of 2025. For those unfamiliar with our Ontario Critical Care Clinical Practice Rounds, it's a webinar series sponsored by Critical Care Services Ontario. Its goal is to help address challenges that health professionals experience while trying to provide the best possible care to acutely ill patients. Our webinars aim to address these issues through education and the sharing of best practices. Previous OC3PRs are available at the CCSO website or on their YouTube channel. In there, you'll see the topic of staffing has been addressed from different perspectives. Building on these previous webinars, today's discussion will focus on staffing, particularly physician staffing, all with the goal of ensuring that there is appropriate continuity of care being provided. The format of our webinars is that they will provide an opportunity for you, the listener, to submit questions, which today will be fielded by Dr. Jennifer Sang, a member of the OC3PR Executive Committee. To submit questions, please type and send them directly to the individual named Q&A for question and answer. As before, please do your best to keep yourself muted. Please again fill out the survey at the end of today's webinar, as your feedback is greatly appreciated and will help us plan future events. Today, we are fortunate to have with us two experts to help us explore the continuity of care in critical care with an emphasis on staffing models. First is Dr. Hannah Wunsch, who has been with us before. She's now a distinguished professor and vice chair for research in the Department of Anesthesiology at Weill, Cornell Medicine. She trained in anesthesiology and critical care at Columbia University and holds a master's degree in epidemiology from the London School of Hygiene and Tropical Medicine. She was a Canada Research Chair and is currently funded by the NIH and the U.S. Department of Defense. Her work focuses on the organization and management of critical care services, with a particular focus on use of large databases to understand resource utilization and long-term outcomes of critically ill patients. She's the author of the recent book, The Autumn Ghost: How to Battle Against a Polio Epidemic Revolutionized Modern Medical Care. Presenting with her is Dr. Dominique Piquette. She is an adult critical care staff physician in the Department of Critical Care Medicine at Sunnybrook Hospital. She is also a scientist at the Sunnybrook Research Institute and is an associate professor in the Interdepartment Division of Critical Care Medicine at the University of Toronto. Her research interests are primarily focused on better understanding of how physicians learn to care for patients and how to conduct impactful research in changing critical care clinical environments at the postgraduate and post-certification levels. Dr. Piquette is also actively engaged in the critical care curriculum development and evaluation, as well as teaching at various levels. Our objectives today are to better understand the origins of staffing models in ICUs that focus on longitudinal care provided by individuals. We also hope to identify the ways in which modern care of critically ill patients differ, and finally, to discuss the potential trade-offs, risks, and benefits of models of care that emphasize continuity over shifts. Thank you both for presenting, and I look forward to both of your presentations and the discussion afterwards. Hannah, I believe you're starting, so I'll pass it on to you.
Thanks so much. It's a real pleasure to be with you today. Of course, it was advancing before, and now it's not. Here we go. So I'm going to give maybe a little bit more of an overview of this issue of continuity of care before Dr. Piquette, I think, is going to focus more on trainees. As mentioned, I do have some research funding, and in fact, my NIH and CIHR funding is on staffing models and a survey, in fact, that we're doing in Canada right now, funded by CIHR, about staffing in ICUs. So, I want to start out by making the point that, of course, continuity of care is a patient-centered outcome. I don't think there's anybody who would ever say, I'd rather not see the same doctor and nurse every day, right? Like that's sort of a given. So I'm starting with that point that like that is something that we would all wish for. But I want to explore really what enables or enabled delivery of incredible continuity of care when critical care started. Why is continuity of care so much harder to deliver now? And then are there actually benefits to a decrease in continuity of care, which feels kind of paradoxical, and to explore that a little bit. So just to take you back in time, 1958 is really the first ICUs in North America, and in Canada, it's Barry Fairley who founds the first ICU up at TGH in Toronto. So to recognize that critical care is a relatively young specialty, but that the kind of staffing models that we actually still think about today really come out of the 1950s and those kind of original approaches to care. And of course, the ultimate continuity for anyone, whether physician, nurse, or anyone caring for patients in the ICU, would be that you're available working on call 24/7, 365 days a year, right? That's the ideal. But in fact, back in the day, and actually relatively recently, certainly for physicians, an on-call schedule working 24/7 for a month straight was in fact the norm. And I have a colleague at the University of Michigan who told me that he did a shift like this up in 2010 at the University of Michigan ICU. Now, I find this incomprehensible to imagine being able to do this. And I think we should explore how and why people could do this. And so this is data actually from the United States, but I'm guessing it was very similar in Canada. In the 1950s, the percentage of doctors who were women was only 6%. Marriage rate for men was 90%. And the percentage of married women who worked outside the home was 20%. And so, and I think probably even lower for couples who were in high income brackets where, women didn't need to work outside the home. So fundamentally, doctors in the 1950s were married men with wives at home. And that completely changes, of course, the construct of what is feasible in your job when you don't have a kind of modern life and modern marriage or, modern world in any way. This is just some more data. This actually only goes back to 1965. And so if you extrapolate backwards, this is parents' time and housework per week, that fathers in 1965 were doing 4.4 hours and mothers were doing 31.9 hours, right? And we know that, that's more balanced now, as you can see over time out to 2011. And then this is a fascinating one, parents' childcare time. Back in 1965, so we're not even back in the 1950s, 2.5 hours per week of childcare time provided by men who were fathers. So really gives you a different perspective on what were the other pulls on people's time when they weren't at work and how they might be able to do that. Now, from the nursing perspective, this is, apologies for the blurriness of this photo. This is a nursing residence in Copenhagen at a hospital that existed back in the 1950s, 60s, where the nurses lived right next to the hospital. And this was the norm, the residential housing, that if you were a nurse, that this was what was expected. And I really think it's important to recognize that for nursing, there was this concept of it being a calling, that your entire life was going to be about nursing. You had to be unmarried, right? That changed variably in different countries, but really up through the 1950s, a lot of places, you couldn't be married and be a nurse. You often lived on site. And then there's this funny paradoxical piece that actually nursing shifts were shorter, 8 hours on average, where a lot of the time now they've expanded to 12 hours, but I put in there often longer just because, because this was their entire life, they were often kind of there 24/7 in a way that was very similar to the doctors. And so I think we need to kind of also explore what was going on in ICUs back in what I call the days of the giants, as one of my attendings when I was an intern described it as. And we have to recognize that ICUs were much smaller, so you weren't taking care of that many patients on a given shift. What could be done for patients was not a lot. So of course you could come in day out because it wasn't exhausting to prescribe an aspirin and maybe change a vent setting on someone the way it is when you think about everything we do for people now. How much help was there in terms of number of people? Well, in academic centers, they were, of course, very well staffed. So although you might be on a lot, there would generally be a lot of other people around to support you. And then who does nights and weekends? Well, the junior trainees. And I think it's important to recognize that certainly for physicians who were, quote, on call for a month straight, they were not being called. And I can attest to that as someone who trained in an ICU in 2003, not that long ago, in a MICU at Columbia, where people died at night. We didn't call the attending. We prescribed $6,000 medications without asking the attending, right? So it was a very different model for what was expected of people at the bedside, but then also went away from the bedside. And then the final piece, and this is relevant to everybody who works in the ICU, certainly not physicians, expectations of patients and families was pretty minimal. Visiting hours were very limited. The amount of time that as a nurse at the bedside you would expect it to be updating families was almost zero. And so it was a very different pull on people. So why is continuity of care therefore so much harder to deliver now? Well, it's pretty obvious. ICUs are bigger. So just in a given day, you're dealing with more. The workforce is more diverse. And so there are bigger pulls on people outside of work. Administrative and other support has decreased. And I find I make people very uncomfortable when I point out that in the 1950s, I would have been someone's assistant, right? I wouldn't have been a colleague, a doctor at the bedside. I would have been their other half dealing with all their paperwork. Patient complexity has definitely increased. So what can be done for an individual in a day has changed dramatically. The speed of delivery of care has increased in expectations. Length of hospital stay has decreased so that we're cycling more people through and having to get to know more patients more quickly. And family expectations regarding communication and updates has absolutely increased dramatically. So you put all of this together, and of course, for anyone working in an ICU, a given day and expectations about what the interfaces and interactions are has changed a lot, making it very hard to contemplate doing multiple days in a row, and then on top of that, the idea for physicians doing nights as well. We recently published a survey of ICU staffing in the United States. As I mentioned, we're in the midst of doing the one for Canada and hope to have data soon. And some interesting data came out of this. We asked about the ICUs, and this is 596 US ICUs. That sounds like a lot, just to be fair. This is only probably about 20%, if that, of ICUs in the United States. So it's actually a pretty small sample. But what we found was we've moved the majority of intensivists to working 7 days straight. But you can see that there's actually some where it's shifted now to 5 days, and also, some that are still back in the days of making people do greater than 14 days. So we don't actually have great agreement about how many days people should be doing in a row, but definitely there's been agreement that people can't do a month and that it's needed to shift downward in terms of those numbers. And I would argue, and I'll show you some data, that probably 7 days is too long as well. This is the work that we did looking at the association between consecutive days worked for intensivists and outcomes. And this is actually Australian data where we had survey data on how many days intensivists worked, and we were able to link it to patient level data in their ICUs. Our primary outcome was actually length of stay. We didn't think we would see a difference in mortality, but we were actually surprised. We had competing hypotheses. Some people in the group thought that if you had better continuity, longer duration of consecutive days, that people would get to know their patients better, know when they're ready to leave, it wouldn't delay things and that would be better. But in fact, what we found, which was my theory, was that actually, you kind of get stuck on patients and you get this narrow vision. And that in fact, how often does somebody new come on? They're like, why is this patient still in the unit? And the person's like, well, I was kind of checking these last few things on them, and I just wanted to keep them an extra day or two. And then they sign off and you're like, no, get them out. Like, they're fine. Right. So I think, that's speculation because all I have is the data, but I think that that's what's going on here. And that this actually speaks to the idea that there may be some patient benefit to getting people out sooner. And we split here by survivors and decedents because we wanted to make sure this wasn't just people coming on and saying like, oh, this is going nowhere, let's stop care and, transition to comfort measures. But you can see it was those who survived as much as it was for those who died. And then this is a really neat paper that was actually done by Andre Amaral up at Sunnybrook many years ago now, 2014. But I think is again kind of a neat assessment of going against our biases, which is that, of course, patient care is always better if you know the patients well and have that continuity. And this looked at the fact that fellows who were the ones in the hospital at night sometimes were doing 24 hours on, where they knew the patients from the day and kept them overnight. And then sometimes somebody else was coming on and taking care of those patients for the night. So any individual patient was sort of exposed to nights of kind of cross coverage and nights of continuity. And what he found was that, in fact, increasing episodes of cross coverage was associated with decreased ICU mortality. And what was really nice about this paper was it wasn't just this observation. He was absolutely able to dive a little bit into the mechanisms. And what he found was here where the fellow cross-covering yes versus no, that there were more nighttime decisions going on when there was cross-coverage by a fellow. There were more CT scans ordered. There were more changes to antibiotics. There were more changes mildly in ventilator settings. And there was also quite a lot of difference in the fluid management. And I think this speaks to the fact that our patients are so complex that you can be with them all day and just not see something, right? That's important, that maybe they're starting to deteriorate and getting septic, but you've been with them too long and you just can't see it. And it's actually really helpful to have someone else come in and be like, have you noticed their heart rate's now 122 when, earlier it was 100? And things like that, that suggest that because of the complexity of our patients, we actually need more and different eyes on them, which goes a little bit against this idea that continuity for patient outcomes is always the answer. I want to throw in there, this wasn't in the title of sort of the session, because it's really not just about learners and patient outcomes, it's also about staff outcomes. And this is a nice study that took advantage of the fact there were a couple ICUs where sometimes they did 7 days in a row, sometimes they did 14 days in a row as physicians, and did surveys at the 7-day mark, and then for those who did 14 days at the 14-day mark, surveys about burnout and fulfillment. And what it really showed was at the end of a 7-day rotation versus a 14-day rotation, there was a lot more burnout in those people who either were facing another 7 days on or had finished those 14 days on. And of course, the fulfillment was reversed, suggesting that there may be real repercussions to having people do these long durations in the ICU that are not just about the staff, the patients. Not a lot of data on nurses and nursing shifts and continuity. And apologies, I don't know the data very well, I'll be honest, because my focus in my research is physicians. But I thought this was a nice one. There's sort of two different aspects of continuity for nursing, right? One would be assign the same patient multiple days in a row. But the other one is about the duration of the shift you're on, right? With the idea that maybe doing 12-hour shift is better because it's fewer handoffs in the course of a day for patients, and you'll be, any individual nurse will get to know them for longer over the course of the day, that maybe this is better. But this is an interesting study that came out looking at patient dissatisfaction associated with the duration of nurses' shifts. And what it shows you here, and it's a little hard to understand, so I'll sort of take you through it. For the longer shifts, greater than 13-hour shifts for nurses, this is the percentage, or the outcome was basically a poor rating by the patient, less than or equal to 6 out of 10. And they were more likely to give a poor rating for their care when there was a longer duration of the shift. Same thing, patients would not recommend the hospital. That positive number there is an association that they were more likely to not recommend the hospital, more likely to say that that sometimes or never that the nurses communicated well, that the staff explained medications, the pain was controlled, etc. So again, kind of going against this idea that continuity is always what even patients themselves find beneficial. And then going back to the issue that it's also about the staff themselves, they found, in fact, that burnout was much more likely to be reported in those when they were doing longer shifts, job dissatisfaction, and intention to leave the employer within a year. This is a little bit of work just to speak to the issue of others who are not physicians and nurses in the ICU. A table from our study that we published from the US, and again, we don't yet have the Canadian version, but really trying to get for the first time a handle on understanding of who's part of the team rounding every day in the ICU. So this is less about continuity in terms of an individual, but more about, do we even have continuity weekday to weekends for some of these individuals? And if you look at this, intensivists, they're not always there on the weekends apparently, but they're, not surprisingly, they're pretty much 7 days a week. But and clinical pharmacists, we have a huge drop off, and respiratory therapists, a big drop off on weekend rounds. And I think this just speaks to the fact that the development of others in the unit who are not physicians and nurses kind of came later, right? It wasn't part of that 1950s model of care. And so it started out from a different place in terms of expectations, in terms of what days of the week you'd work, and it being a sort of more, quote, normal schedule. And then what you see when you look at others, social workers, dietitians, physical therapists, occupational therapists, et cetera, that there's very little presence. Again, this is US data, but very little presence on weekend rounds. So to put it all together, this I put in parentheses here, physician service. This was a paper I wrote that was focused on physician continuity of care. But to be honest, you can just remove physician from everything on this image and you get the same thing, because it's really questioning our understanding and our valuing of continuity of care by providers, with this idea that that's where we're coming from. Baked into us, this is the idea that that's always better. And we do have to recognize that with modern patients, modern care, modern life, that we may need to recognize that, in fact, there are benefits to moving away from that. And for anyone who's interested, this was the article it came from, which was entitled Getting Out of the 1950s, Rethinking Old Priorities for Staffing in Critical Care. So I'm going to stop there and hand it over to Dominique, hopefully a kind of thought-provoking overview of some of these issues, maybe make you feel a little bit better when you're unable to be there 24/7, 7 days a week, but also recognizing that we need more research on this topic to figure out what are going to be the best models to best and most safely deliver care for our patients.
Thank you, Hannah. I'll get Dominique to put up her slides and we'll pass it on there. Thanks.
Thank you very much, Hannah. And thank you to the host for inviting me. So I don't have any direct conflict of interest relevant to this talk, although I've received grant funding from different organizations, including for a study that I will mention a bit later. And as a disclaimer, I've also done a lot of 24 hours calls, so that may sometimes influence the tone of what I'm going to say. So maybe I'll start by saying, well, why talking about residents? And that might be obvious to some of you, but maybe not to all of you. So obviously, residents provide the majority of the frontline care to patients in teaching hospital. And their work and the level of supervision that they get clearly affects the quality of care that is provided in those institutions. And their schedule, either in terms of shift length or overall duty hours, also actually influence care continuity. And I thought I would choose a theme of pendulum to address this topic, because as you will see in a minute, over the last 20 years, there's been a lot of shift in the pendulum and in the balance of how we see the resident schedule and duty hours policy, and not necessarily a lot of evidence to support a choice over the other. So as I'm going to use a little similar frame to Hannah, actually, to describe resident scheduling and continuity of care. But obviously, I think we all agree that we don't have much choice of finding a model that provide care over 24 hours and 7 days a week. And ICU clinicians need to actually provide that coverage. In Canadian ICU currently, the standard of care is still for in-house 24 hours. So the same resident works both days and night and then goes back home on a post-call days after heading over to the team Monday time. There's an exception in Quebec where there's been a change in policy where over there the residents typically do 12, 14 hours overnight. There are also other schedule availables that have been tested, as we will see, where the time shift is actually shorter, often duration of 8-10 hours, and then the rest of the shift is actually completed or done by an on-call team or an on-call resident. And obviously, as Hannah already pointed out, the shorter the shift length, the higher number of transition of care. So in theory, if we have longer duty hours, then we have better continuity of care, as Dr. Wunsch explained. And then one of the obvious advantages would be that we have greater patient safety. However, as she nicely demonstrated, longer duty hours also mean a certain amount of provider fatigue, and that can certainly compromise patient safety. It can also affect provider long-term well-being. And that also, as we know from the literature on burnout, have effect on patient safety or the quality of care that is delivered. In teaching hospital, when we have residents or trainees or learners doing some of the work, the clinical work, there's an added layer of complexity there because obviously clinical care here is and residents are expected not only to provide a service, but also to learn from their clinical experience. And through that, become independent practitioners that eventually can provide safe care. Well, continuity of care has been arguably meant to be have a positive effect on trainees' learning because they can see the effect of the decision that they make and learn to know their patient better. But fatigue could also have negative impact of learning. And therefore, it becomes very complicated to understand what longer duty hours can have in terms of global impact on patient safety when there's so many potential conflicting effects. It's clearly not a linear relationship. So what do we know actually currently about the impact on resident schedule and care continuity and patient care? Well, I'm going to do a quick review of the key regulation studies and reports that have been produced mostly in Canada and in the US over the last 25 years. And we'll do so by looking at 3 key periods that really capture those big swing in the pendulum in the discourse on resident duty hours. And it's probably worth noticing that the regulation and the policies, the big cycle on these figures are typically preceded the evidence, the smaller full circles on the figure that was generated by a study that actually collected data about the change that were already implemented. And I'll come back to the why that might be the case. So if we go back to the pre-2003 era, where the motto was really the more the better, and when I say more, I mean more work. And notice I didn't say the more the merrier, because obviously that caused all sorts of problems. So as Hannah pointed out, the numbers of our works, even up to the early 2000s, was actually extremely high. There's surveys showing average working weeks in the US in the ICUs prior to 2003, above 100 hours a week. And obviously people start wondering, well, maybe the fatigue is not so good for the patient, and maybe the fatigue is not so good either for the residents. And there was certainly an emerging body of evidence showing that acute sleep deprivation, especially in the context of chronic sleep deprivation, is actually problematic and can lead to 3 types of sleep problems. So it's not only just about the sleep loss that happen, for example, over a shift. It's also about the negative effect that it has on the circadian cycle, which affect the sleep while trainees or clinicians are off duty. And also, even when people have short periods of time of rest, for example, in the middle of shift, there's evidence showing that it leads to this kind of sleep inertia, which is the technical term, but essentially means that your brain is quite dysfunctional in the first hour or 2 when you're waking up after this short nap. We also know from the literature that sleep loss has actually affected human performance in a wide range of domain, cognitive, physical, and obviously in terms of mood as well. And that's true in literature on pilots, nurses, astronauts, athletes, and yes, even amongst physicians, who sometimes seems to believe that they are not affected by that. Now, around 2003 came the case of Libby Zion. And she was an 18-year-old female who actually died overnight from a rare drug interaction under the care of 2 junior residents. And that led to a very highly publicized court case and then a public debate about the way residents were trained, specifically about the effect of working for so long hours. From that emerged the Weill commissions that made the recommendation, which was then adopted in New York State as a law that actually limited resident duty hours to a maximum of continuous period of 24 hours on call plus 6 hours to hand over care, and as well a maximum of 80 hours a week. So basically, that started marking a shift in the duty hours discourse. The fact that maybe more is better to a certain extent, but too much of work can also be dangerous. So that led to a second era where that became less is maybe better. And during that period, different jurisdictions actually implement duty hours regulation, but actually for different reasons. So in Europe, worker union pressure actually led to European Working Time Directive. And slowly by 2009, the working week hour came down to 48 hours, which shift length up to 13 hours. And the healthcare world actually just followed the same rule. Similarly in Quebec, concern about violation to the Quebec-Canada Charters of Human Rights made by resident union is actually what led to the adoption of shorter on-call shifts, sadly, after I left Quebec. So, and as we just discussed, the US changes were really driven by patient safety concerns. And those are what triggered the initial push towards reduced working hour. Obviously, there was some support from emerging evidence. For example, this landmark study published by Landrigan in the New England Journal of Medicine in 2004, actually it was the first RCT in the ICU, but that showed that there were fewer serious medical errors with shorter shift, 16 hours. So that kind of shorter daytime, longer nighttime model that I was referring to. But that was including only 20 interns, and it was done in only 2 ICUs of 1 hospital. It also didn't necessarily emphasize the fact that they also changed a little bit their supervision model and provide more supervisions to the trainees who were doing calls overnight, and that actually they readjust their structure, which is not simple to do in practice, and actually mobilize a third more interns to actually compensate for the lack of the trainees who were post-call, but also now absent when they were pre-call before starting their night shift. So that study was actually followed in 2008 by the Institute of Medicine report on resident duty hours. And that concluded that really patient safety depended on allowing for enough sleep in a day and a week, optimizing the handover process, and supervising adequately the junior trainees, especially the interns, who are the equivalent of PGY1 in the States. And in part because of that report, the ACME, which is the organization that is responsible for regulating the work of the resident in the States, actually implement their duty hours limitation in 2011. And the major change, there were a few, but the major change was for the interns, so those PGY1 type of resident, to do a maximum hour of 16 shift rather than the typical 24 to plus time for handover. And over the next 10 and 15 years, there was a series of studies that were published to look at the impact of dose regulation, and that were eventually summarized in 9 systematic reviews. Actually, there's a 10th one that has been published more recently, and that report actually on 3 types of outcomes. So patient outcomes, obviously, but also educational outcomes and well-being outcome from the resident perspective. And the broad conclusion of all this, and you see that the bigger the arrows, the higher the number of studies that look specifically at that income within that review. And obviously the upward arrows are positive effect, and the flat arrows are a neutral effect. So you can see in a nutshell that for patients, most of the studies showed actually no effect, with small numbers of studies showing actually both an improvement and actually reduction of patient safety. Whereas in education, again, most of the study probably neutral, but results are conflicting and a bit all over the place. And the only consistency really is within the well-being domain, where most of the studies show either an improvement or a neutral effect. It's important to say that all those studies report actually a pretty poor quality of the data and of the original work that were included in those reviews. In addition to the lack of clear benefit of shorter shift on patient outcome, there's a lot of people that actually raise concern about other issues. For example, the transfer of care and that loss of continuity, where handover is not necessarily emphasized during education, and it's still not, leading to potential actually lapse in care. Also, the lack of professional growth of residents who got less exposed to, especially the surgical and procedural type of specialty, and therefore were felt to be less independent by the end of their training. And also a shift of mentality and a certain loss of professionalisms, where people would kind of come in, do their shift, and move on without caring too much for tasks that were left unfinished or pass on to the next team. There's also in the literature the discourse that really, as physician, although there's a lot of evidence showing that working 24, 28 hours doesn't make a lot of sense physiologically, that we are kind of special, and that actually that data doesn't apply necessarily to physicians or other highly trained and intelligent healthcare professional. But you can see that suddenly there's a shift again of this pendulum, where maybe less is not really better, and maybe it's even worse, actually, in terms of patient care, especially. And that explained this following period, which really is characterized by studies American studies at least, that actually focus on comparing regulation to older system and kind of coming back to the previous era, that instead of labeling longer shift, they labeled it flexible duty hours. And there's 2 large trials that are usually quoted in the literature. So the first trial and the iCompare trials, which are quite similar. So large studies, non-inferiority study that look at basically the duty hours from the 2011 regulation, with a more flexible schedule where people are not limited to a 16-hour shift for the junior trainees. The first trial looked at surgical programs that had compare programs that implement the 2011 regulation to programs that actually went back to a more flexible. And they didn't show any effect on patient outcomes, and they did show more violation of the 80 hours maximum week, and report poorer personal health, especially within the women trainees. Quite similar results for the iCompare trial. It's very similar design, but amongst medical or medicine program this time. And again, showing no effect really on patient mortality, but potentially this is dissatisfaction of the interns regarding education and well-being in the longer or more flexible schedule, as they call it. So this resulted in actually in another modification of ACME duty hours restriction that now actually removed the maximum 16 hours shift for the interns and went back to the 20 hours model with the same 80 hours work week maximum limitation. So, but I think what we can gain from this literature, and there's other obviously publications that have looked at this, longer duty hours are actually maybe not worse for patient care, or at least, difficult to make general statement about this. They seem to be quite consistently problematic for resident well-being. And longer duty hours is actually probably also of residents, obviously, is actually probably better for the staff or the faculty and the senior trainees that supervise them. Because as the ACME 2011 regulations were incorporated, there was certainly a shift of work and responsibility towards the more senior members of the team that then possibly saw their own well-being going down quite significantly. So I will actually talk quite rapidly from the Canadian situation because we don't have a lot of data. There's a report that came out in 2013 looking at fatigue, risk, and excellent, and basically conclude that there was a need for more evidence. We have a few surveys of Canadian resident opinions showing that for resident, a period of 16 hours appears to be safe, that longer hours working in a row, continuously working actually compromise or is felt to compromise patient care, and that the amount of handover training provided is still quite dismal across programs. We also know, and that won't be a surprise, that current resident well-being is not excellent, at least according to a survey in 2018. I doubt that things have changed much. So they work very hard, they don't sleep very well, and their rate of burnout and abuse on work is actually quite high. So the same organization, Residents Doctors of Canada, actually recommend in their report published a few years ago that all provinces and regions in Canada should work towards a system that limits continuous uninterrupted duty hours to 16 hours or less at a time. We don't know, and we haven't talked a lot about patients and families who are really at the receiving end of all this, but at least there's one survey that report that in Quebec, people often they didn't know that the physicians were working 24 hours, and certainly were against the idea of having shift beyond 16 hours. So are we expecting more empirical data on that topic? Well, it's a bit difficult, and I will just say two words in personal experience with trying to research that area. So we've launched a few years ago already a study called INCURS for Intensive Care Unit Resident Scheduling Trial. Tried to get data about Canadian ICU and also collect proper data about how the schedules are implemented, and look concurrently at three outcomes, comparing the 16 hours and 24 hours overnight schedule, looking at patient mortality and safety, resident education, and also resident well-being. And we also implement a co-intervention in both groups to ensure that there was standardized handover training, which implementation as well as handover practices we're exploring in a sub-study. Recruitment has been extremely difficult. We had planned for 18 sites with a lot of letters of support from all those sites. It was difficult to recruit ICU, and then obviously the COVID pandemic came, which made everything more difficult. And with the implementation of competency-based medical education, many programs have reoriented their residents towards a different rotation away from the ICU. And across the country, there's certainly a general sense that there are fewer residents to actually cover those 24 hours, that fellows and faculty, especially post-COVID, are quite burnt out. And just the idea to modifying anything else to the system is really not appealing. And many programs have been under accreditation review across the country, and there's a lot of susceptibility around, again, disturbing more the system. And some centers have actually, including in Toronto, have actually unilaterally adopted shorter duty hours for other reason and didn't even want to test the 2-resident schedule. So I think hopefully I've demonstrated that our resident duty hour system hasn't been built necessarily on a clear understanding of the trade-off between the impact of different actors in the context like ICU, where things can potentially be different than elsewhere. And that often policies has preceded evidence and actually may continue to do so, because to look at or study resident schedule is very difficult, as the manipulation of research of schedules for a research purpose is really difficult things for people to swallow. So hopefully at least we'll continue to gather additional data as new policies are implemented to study the impact and hopefully come up with mitigation strategy if one of the a group of actors is actually negatively impacted. So thank you so much for your attention. And
Excellent.
I think we're ready for questions.
Yeah, thank you both. And I'm just cognizant of the time as well. I got several questions, and I'll also go to Jennifer in a second. Dominique, I'll give you a little break so you can catch your breath after presenting. For Hannah, hopefully I'm a better father than the 2.5 hours per week that generations past would do. I found it interesting that you noted benefit of the cross covering. I'm actually well aware of sites that have implemented rules at night of what can and cannot be done, because there, as you know, there's always a change of opinion. And in my practice, I try to make a rule of not changing everything on day one. In some ways, it's disrespectful. I was wondering, how do we find that right balance to ensure that, people are changing for all the right reasons? I don't know if you are aware of any evidence or policies, practices that would avoid, the yin yang kind of idea of who's on.
Yeah, no, it's a great point. I think that just the first step is acknowledging that there may be benefit from other eyes on a patient, right? Like, that's actually a novel concept coming from this idea that one doctor or nurse knowing a patient really well is the best care we can ever provide for someone, right? And we're still kind of stuck in that idea as we sort of, go into this modern era. And so I do think that the first thing is just that idea that, there may actually be benefit and differences of opinion and things getting caught that are being missed when you have somebody who just kind of gets to know a patient too well almost. And so, but I also appreciate your point of, like, absolutely, you come back in the morning and you're furious that someone's meddled with something that you had put in place, and and actually it's detrimental to the patient, and you have a good sense of them. And so I think the basic answer is this is a sort of very baby area of research, and so we don't have any sense of that. But I think that, there's two halves to it. One is the recognizing that there are people having other eyes and having other opinions may allow you to catch things in these very complex patients that you're going to miss. Also recognizing that a piece of that is the good handover, right? And I think that actually is the other side to it that does ensure the safety, right? So if they react badly to Seroquel and it's been tried 3 times before, ensuring that information gets passed on to the night team that's taking care of them, right? So I think there's many components that we're not talking about today that would go into ensuring that we get the benefit of those extra eyes without the harms that absolutely can come with, you just walk in and take over a patient, you know nothing about them. Of course, the likelihood you're going to cause harm rather than benefit is actually probably quite high. And I think that, Dominique kind of alluded to this more than I did in terms of this issue of the number of handovers and the great concern around that. And I think that really just speaks to all the data and the research on how do we do good handovers.
No, excellent points. And I think of the days when we used to have two ICU attendings round together, and it was kind of good to get that perspective, and we still cross cover at nighttime, and so there is that bit of that shared discussion. But unfortunately, not everyone can benefit from that. Dominique, as a department chair, I'm certainly well versed with resident issues and concerns. I wonder if there's any evidence or any talk or discussion of, do we change how we not only schedule them on a daily basis, but like the 13 blocks of 4 weeks, kind of the idea of half days every week. Is there any evidence or sites that have explored different ways of staffing? So maybe they have an academic week versus a clinical week. I just worry that, they're being pulled in so many directions that their clinical experience gets diluted concurrent with their academic experience. So is there any evidence of alternative scheduling or that would be of value other than just like on the one rotation per se?
There's no clear evidence. I think anecdotally, so there's especially in critical care, we have programs like, for example, in Toronto, we have a program where people rotate in 5 different hospitals, sometimes with different ICUs within each hospital, versus other programs where people are in the same institution for the entire 2 years of a fellowship, of an ICU critical care fellowship. And it certainly contribute to a certain educational continuity, I would say. And it plays at so many levels. So there are big issues, and there's certainly literature in general about the short rotation system and this idea to get in a new place, which is a bit different than a continuity of care over 24 hours for a patient. But there's a lot of detrimental effect from an educational perspective to have this rotational system. And for many reasons, but maybe highlight 2 or 3. Certainly, the quality of the feedback that trainees get from people who don't know them very well is often limited, and the ability to accept feedback from someone that you don't know very well and that you feel doesn't know very well also is problematic. There's also lots of issues, especially in a context like the ICU, to give trainees autonomy to do things a bit more independently when you don't know and you don't have a good sense of their level of performance. Whereas when you have seen someone work that you've worked with progress and getting increasingly knowledgeable and skilled, then you can more easily let them do more, which often contribute for them to develop in fully independent trainees. So it does certainly affect not only the patient care experience, but the educational experience as well.
That's great. Thanks. I'm going to go to Jennifer in 2 seconds. I would just remind everyone if they could please fill out the evaluation that will come up on the screen or be sent to you afterwards. Jennifer, do you have some questions for our presenters?
I do. We have some question from the audience. I think this question would go to Hannah. The audience asks if there any thoughts on how this data that you have presented in terms of staffing model could apply to community hospitals with irregular access to residents, and sometimes clinician often providing 30 hours of call coverage every other day over the whole week. And how any thoughts on this area in terms of sites that don't have residents supporting the work?
Yeah, I mean, I think it's relevant to places that have residents as well as not having residents, right? Because you still need an intensivist covering. And in fact, sometimes I think that's what's demanded of an intensivist when they're having to teach the resident on top of everything else, maybe even more. And Dominique could speak to that issue. So I don't think that this is actually something where there's a divide between community hospitals and academic hospitals in terms of the fact that we haven't caught up to the realities of modern critical care. I think it speaks to the fact that if you go back in the days, what was a community ICU in the 1970s? Well, it was probably 4 beds, with maybe 1 or 2 on a ventilator. There wasn't a lot you could do for them. You might put in your central line and swan them, and then you're going to kind of like leave them alone for a week. Right? So, I mean, I'm exaggerating a little bit, but really just to make the point that the exact same stressors and pressures are there in all ICUs now. And we're all struggling to figure out how do we have coverage? How do we staff intensivists in a way that's going to even just allow 24/7 coverage, right? And I think that's kind of was the first step, was to say that we need somebody available at night, because there were also places where that wasn't even the case, where you'd have a hospitalist who was available for emergencies in the ICU at night while the intensivist was only working days. And obviously we've moved from that model. I do recognize, certainly in the US, the solution to this has very much been nurse practitioners and physician assistants as support and being part of the team in the ICU. I know that's less common, really, in the Canadian model, if it even exists at all. And interestingly, the data, and this maybe speaks to this point, the data we found in Australia, we were actually interested also in the intensivist to patient ratios. How many patients were you actually seeing in a given day? And was there a relationship with outcomes? And we did in the UK find a relationship with outcomes. There's a nadir at about 8 patients, where that's the best ratio when intensivists for 8 patients. We did not find any relationship in Australia with the number of patients. But what we did find, and this speaks to this issue, was that if we incorporated all the information about how many other doctors were on during the daytime in the ICU, so residents and fellows and maybe even sort of non-intensivist attendings, that ratio was very steady at 2 to 3 patients per doctor. And I think that speaks to the fact that they've found a way, using where they have a lot of trainees, I think, in most of their units, to staff units in a way that does provide for sort of more steady ratios. And the real challenge, I think, in community hospitals is these units that keep getting bigger and bigger and bigger, on top of the sort of the continuity issue, but literally just the number of patients being asked to care for. And I do think that this is where we as intensive care providers do need to start pushing back, when they're sort of like, oh, we're going to add 10 more beds, and no, you're not going to be able to hire anyone new, right? That to recognize that we do now have data to say that is not a sustainable model.
Thank you. Dominique, any comment on?
No, maybe just to say that Ashley, just as we have been in touch with many ICUs, academic ICU, at least across the country for our study, increasingly there's a need for hiring of either physician assistant or nurse practitioner, because the junior residents who used to do the night shift, obviously under the supervision of the staff who's normally not in-house, actually is low enough now that in many centers it's not possible anymore. So they've actually resort to hire people to actually provide care. So I think it's becoming a model that is, is going to get more common for sure in Canada, and has already started.
Thank you. Over to you, Dave.
Yeah, no, I think time is our enemy here, and so I think in the interest of that, if you can stop sharing your screen, Dominique, as well, we'll put up the questionnaire, and for those, thank you both for taking the time to present. And certainly there's no magic answer of how we should staff, and I think we all recognize that. But I do think we all need to understand and appreciate that just because we've always done it in a certain fashion doesn't mean that is the right way. Doesn't mean it's the wrong way either, but certainly we should all be willing to adapt. So thank you both for that. I just also want to thank CCSO, Nancy and Renisha, for all that they do for OC3PR, and thank you to everyone who's been watching, and we do appreciate the comments and feedback. So I wish you all the best, and have a wonderful day on Women's Heart Health Day. I remembered all
Thanks
that.
so much.
Thank you very much.